Hi, class. Now we move on to the family portion of our presentation. The first thing we're going to look at is assessment screening. So when assessing a family for treatment, it's important that our initial interview slash intake includes the entire family together. During this interview, we want to make sure that each member of the family has an ample opportunity for their voice to be heard, to be seen, to share their story, to share their perspective on what's occurring in the family, what their role is. We can use this information to gather the needs of both the individuals and the family as a whole. You want to always pay attention for any signs of immediate danger or threats to any family members, such as child abuse, dangerous levels of drug use, domestic violence, and take any action if necessary. Willingness and availability. Is each family member willing to participate? Are they being forced in the treatment? Willingness is key. I think willingness can determine participation. If there is an issue with willingness, we explore it together with the family. No one should be forced to participate. Availability. What's the availability of the caregivers, of the children? How much time can they devote to treatment with work, with school, and any other obligations? Referrals. What services may an individual and the family need in conjunction with what we can offer? Are our service options a good fit for this particular family? Well, in this case, we've determined that the recommended level of care is multidimensional family therapy. The theoretical framework of MDFT is a multifaceted one involving multiple theories, including family systems theory, which stresses the interconnectedness of each family member to the unit and the unit to each family member. Attachment theory. How do the family members relate to one another? How do they connect emotionally? What's their comfortability with intimacy? Ecological theory expands to include outside influences such as peers, societal expectations, norms, and how are these impacting the family and the individuals. Trauma-informed care, this is the foundation of the framework when trauma is involved, and as it is here. We will discuss this more in the techniques and tools section below. Techniques and tools. The health of the therapeutic alliance with each family member, especially the parents, can greatly determine the outcome. Do they trust us? Are we connecting with them? Do they sense both our care and our neutrality? Encourage active listening when someone is sharing. It's important that they are being heard. Layman judgment will most likely be present. Our job is to maneuver around such defenses and allow emotions to be touched upon. This brings me to the narrative connections. We can gather much information through listening, information into attachment, peer influence, into what needs are not being met, unprocessed trauma. Trauma-informed care is like the preparation and consistent nurturing. This is an analogy of the soil so that plants can grow. This requires treating each other with respect, softening the body for sensitivity, and listening to understand the other and the self. Treat each person with respect, genuine sensitivity for their experience, and empathize with them to gain an embodied understanding of how they feel. This is kind of what we're trying to bring to each session to mirror to each individual, to the family as a unit. Goals and objectives. A good place to start would be with the parents, the heads of the family. The children have learned and continue to learn from how the parents relate. The parents must address their own issues and their own relational struggles. The arguing and domestic violence has already traumatized their children, Betty and Sean, and children need a sense of safety to thrive, and they do not have this in their own home, nor outside their home, considering their neighborhood is dangerous. It is important for the clinician to maneuver carefully here. There is a tendency for the parents to blame the child, to use the child as the kind of, that's how therapy starts. We're here because our child has this issue, and Betty in this instance, and they can do this to avoid responsibility. So we need to tread carefully. A good way to do this would be to establish a connection between the parents' upbringing and their possible unmet needs and trauma. This can build a bridge of compassion between themselves and then to their children. It can help the parents to acknowledge their part and accept responsibility, not blame, not shame on you, but responsibility. And what comes with this is they have the opportunity to now do it differently. It's an empowering stance. Improvements in the parental relationship can then lead to improvements in other relationships in the family. The blaming can cease and they begin to communicate more compassionately. And we mirror this in sessions through active listening, empathy, and utilizing playful activities in sessions that include all family members. Trust, trust. Trust building. Trust is the foundation of relationships, of all relationships. How safe do the family members feel with one another, with themselves, with us? We can show them what trust feels like with our presence and our alliance with them and build upon this through the sessions. So finally, we get to Betty's drug use. Should this be at the top of the list? Perhaps, or perhaps not. Remember, we are operating through a framework of family, attachment, interconnectedness. So as the relations improve, will Betty? We do focus on Betty on our individual sessions with her, but she is part of the family and not the focus in family therapy. Time and sessions. I would say 2 sessions per week, and we mix those sessions up based on needs. We meet individually with family members and then with the family as a whole. Therapy can take, putting a time frame on how long it will take or how long it should take. That's not an easy one. Um, they say it's between 3 and 6 months. I put preferably 6 months because I do believe that this is a longer, to rebuild relationships and for each person to kind of, especially the parents, to go within and kind of start changing some of their relational dynamics. I think this takes a little bit of time, so I put preferably 6 months. So let's start with the strengths of the intervention of MDFT. The holistic approach, it focuses on the individual, the family, the relationships between them, peers, trauma, relationships with the outside world. It approaches healing from a much broader view, thus enabling much broader healing. Family involvement. It seeks to strengthen the relational dynamics between all family members, and this this can develop family unity, which creates the much needed sense of safety for all family members, most importantly, the children. Shame and blame. MDFT asks all members of the family, particularly the parents, to look within themselves, to share their stories, to take responsibility for their part in the family, and it can greatly reduce the shame felt by the quote unquote problem child or the one with the issue, and in this case, Betty. The focus is on improving family relations and not just a person. MDFT has been proven to be an effective strategy in dealing with adolescent struggles, particularly with substance use and trauma. So it's evidence-based. Some of the weaknesses of MDFT: time consuming. It requires 2 days per week for sessions, and it can last up to 6 months or longer. That's a big ask. It's a worthwhile ask, but some may not be able to commit to that time-wise. The willingness of family members is key. One parent decides they do not want to participate, it will make it difficult to treat the family, considering each family member is just as important as the next. Complexity. There's many moving parts to MDFT, from parental relations to sibling relations to child-parent relations. Then you got the substance abuse to peers and outside influences to past and present traumas. So the flexibility of the clinician to maneuver through all the alliances needed to be formed is demanding. The process for the entire family requires much. It is a demanding ask of the family. So for methods of evaluation for MDFT, family dynamics, from the starting with the initial interview and what we witnessed as a clinician, what we saw, what we noted. How is the family relating to one another as compared to from the start? Communication wise, relating to each other, behaviorally, but mostly focused on the relationship dynamics within the family. Behavioral changes. How are members responding to stressors? Have coping strategies improved? Check-ins. Checking in regularly with family members to see how they feel, how they are doing consistently. Objective goal setting. To revisit the objectives and goals we noted at the beginning with the family. Is there progress? Do the individuals feel like they are making progress? Academic performance. How is the child performing in school since the start of therapy? Is there any improvement? Do the teachers note any improvement? How does the child feel about their progress? The clinician's sense. What does the clinician gather regarding progress in relationships, behaviors, and the process of change? What has the clinician seen as a witness to this process in the family? So for prognosis, I think prognosis is determined on a case-by-case basis. It's difficult to determine prognosis because there are so many moving parts with this type of therapy. I do believe parental responsibility is a large determinant. The willingness of the parents to work on themselves and their relationship. Severity. How severe are the issues present? In this situation, we have domestic violence, we have trauma, we have drug abuse, co-occurring disorders, and is the parental relationship repair possible? Is it something that they want? So all these kind of factors can determine the prognosis for the adolescent and the family itself, for Betty and the family, and Sean as well. Family commitment. Will the family remain committed to the process and show up to the sessions? Can they show up? Will they have the time? Will the time be there, in a week or 2 or 3? Will they lose focus? Things like that. So the ability to commit and stay committed is very important. The therapeutic alliance. How safe do family members feel with the clinician? Is there trust between the clinician and each family member? I think it's really important that the parents trust the clinician. I'm not saying that the children don't need to. I just think that the parents kind of can be the driving force in these situations and determine whether therapy is needed or not needed. So I think the trust of the parents with the therapist is extremely important for prognosis. Other factors, unseen occurrences, loss of jobs, unexpected health issues, etc. These can all kind of put the kibosh on the forward movement of therapy and can also stall it. So again, there's so many factors at play, so prognosis is tough to determine. But I think family involvement and willingness to commit and, kind of work through the process of change and, the willingness to be vulnerable. I think that's the biggest one for the parents, especially. I think is a huge determinant in prognosis. Empirical-based practice. Research article 1, treatment techniques and outcomes in multidimensional family therapy for adolescent behavior problems. Summary. Positive outcomes for adolescent drug use have been correlated with the integrative approach of MDFT, whether it's the inclusion of family members, the factoring of outside influences such as peer relationships, or the new approaches learned by both the adolescent and the family in treatment. The integrated model seems to benefit the adolescent and the family in the long term and the short term by less behavioral issues and less drug use. Inside out, working with the family and developing healthier relational patterns seems to benefit how the adolescent then interacts with the outside world, such as schools, relationships with peers, relationships with others outside of the family. Outside in, the new ways that the individual learns to relate to self and others through individual treatment sessions with the clinician seems to benefit how they then impact family, less stress, etc. Research article 2, parenting practices as mediators of treatment effects in an early intervention trial of multidimensional family therapy. Parental monitoring. Since adolescents rely heavily on parents for transportation, which friends they're hanging out with, who gets them there, their leisure activities, what they choose, the parents have a big say in this. So the more involvement that the parents have in the child's life, the less chances of that child getting caught up in the wrong type of behaviors. Um, and I think that kind of ties to the family functioning in a sense. You usually find that close knit type of when I say monitoring, I don't think it's monitoring in the sense of keeping tabs all the time on your child and invading their space. I think it's more about having a close knit relationship with communication, being connected to the adolescent being connected to the parent, activities together as a family, having an active role in your child's life. I think that's where family functioning comes in to predict less issues with drug use and behavior. Here's reference page 1. Here's reference page 2. And finally, reference page 3.